Around 2 weeks ago, my 2-year-old daughter got unwell. She started breathing heavily and was upset around midnight after having been fine the whole day. Classic. Every pharmacy was shut and I had to decide whether she would be fine to go through the night or needed to go to the emergency department. At that point, I was terrified, even though it is quite literally my job to see and treat these children every single day. And I had all the equipment at home to examine her pretty thoroughly. Thankfully, she's all right, but looking back, I can't help but wonder if having a sick child was that scary for me as a trained doctor, then what is it like for the average parent? That's why in this video I want to give some information about common childhood symptoms like cough, diarrhea and vomiting, rash, the things we look out for with them and make us worried, and some measures and information about treatment. But the information provided here is for educational purposes only and does not substitute a visit to the doctor, please. I'll go through the information first and then we're going to have a quiz at the end to make sure that you are paying attention. So let's say your child has a cough. What would a typical history be? So a 7-year-old comes in with a 2-day history of a dry cough, is breathing well, they're not producing any sputum, they are eating significantly less than usual, they're still drinking enough, passing urine 4 times in 24 hours, no diarrhea and vomiting. Now, I see this kind of patient quite literally about 15% of my clinic are people who present like this. And when I hear that, you don't jump straight to a diagnosis. We know what the most common diagnosis is. That's a viral upper respiratory tract infection with that kind of presentation, especially if the family has been unwell around the same time. That indicates the virus is jumping from person to person. I look for deviations from those symptoms that could indicate more dangerous diagnoses. And what do we call those deviations? We call them a similar thing to dating red flags. So what are our dating red flags? Yeah. So a narcissist. The narcissist. Someone, if they have a cough, we will be concerned. Why? It means that there is more likely a cause here that is not an upper respiratory infection. It should have resolved by that point if it's a viral infection. What else? If it contains or produces blood. That in somebody younger could mean it's a pneumonia, is the most likely thing. If someone's older, has smoked, then it could be more indicative of the big C. But that's probably not on our radar for children, although never say never. The other thing is, have they had a fever for more than 5 days? What happens then? Sometimes, again, more serious infections, pneumonias, vasculitis like Kawasaki disease can present with fevers that long, especially if the child is more unwell, i.e. not drinking as much, passes urine twice in 24 hours. Usually we say if someone's passing urine 3 times or more, then that is typically adequate hydration. Now, the other thing that we look for is gland swelling. That means that they could have something more like mononucleosis, or potentially if they also have night sweats, the cough lasts longer, they've got weight loss, then we start to wonder, could there be something like lymphoma happening here, which is also a possibility. So, night sweats. And weight loss. Now, lots of that sounds scary, but this is all in the realms of zebras. Usually we're talking horses. Anyone who's watched House MD will understand that reference. Zebras are very uncommon diagnoses, but we always need to think, when do I actually need to act urgently? And I think that's what I want parents to get away from this. Not that, oh, there are loads of scary things. It's that if there is something scary that could happen, then yes, I should see a doctor if I am concerned at all. And if these things happen, see the doctor even faster. When we're looking at a child who has a cough like this, what are we looking for? Well, usually if the child is playing around, they are smiling at me, being cheeky, they are able to, say, sit up if they are a younger child or a baby around, say 7-8 months, then okay, that's reassuring. So we look and observe their activity levels, but we also look for specific signs in the chest. A cough really is initiated from irritation at some point in the airways, so it indicates a respiratory problem. And so we listen to the chest, we look at the chest. Of course, as a parent, you're not going to be listening to your child's chest. You're not trained how to use a stethoscope. But if you look at the chest and you notice that the ribs are indrawing, if you notice the child is pursed lip breathing, is going like this, then that increases the resistance as the child is breathing out, which indicates that there is something that's collapsing the airways. So they're providing extra resistance to keep the airways open. If there's tug just under here, which we call tracheal tug, or if there's flaring of the nostrils, then those are concerning signs. Also, you might hear sounds on breathing in. That's stridor. And when we hear stridor, something like that, that's a sign of croup, which is a viral infection, and that needs medical attention. If there's a sound on breathing in, definitely you need to see someone. Now, if we're listening with a stethoscope, a sound on breathing out is known as wheeze, but if we're listening just with our ears, won't really be able to discern if there's wheeze or not, because sometimes the secretions from the upper airway can interfere with that and produce noise when there isn't. So lots of the time parents tell me, my child is wheezing, but that isn't really true wheeze. It has to be heard with a stethoscope. So what do we do? Now, in most of these situations, the child's going to be breathing fine, they're going to be playing, they're going to get their appetite back in a good few days, and the parents usually, well, you may have just observed your child for a couple of days, 2 or 3 days, and they will be able to go back to normal within 7 to 14 days. Things that do not work include over-the-counter cough syrups. They're clever marketing, really don't do very much at all. The antibiotics for viral infections also do not work. They increase resistance, and they also, in the long term, increase the chance that the child develops autoimmune conditions and potentially asthma as well if we use them when they're not needed. So please don't insist on antibiotics if the doctor tells you it's a viral infection. They might just give it to you to try and get through an easy clinic and go see the next patient, but it's not the right thing to do. We overprescribe these things way too much, which is part of why education is so important. The things that may have some evidence include vitamin C, high doses. Of course, you want to be checking the labels to make sure you're not giving too high a dose. There's some evidence it can help. Also, steam inhalation may help a little bit. So I always tell parents, oh, you can switch the hot shower on, and then if you get them to do at least 10 deep breaths with the windows closed, then that steam will possibly help to loosen some secretions and give them some comfort. Vicks vapor rub on the chest if the child is old enough. Otherwise, paracetamol and ibuprofen for fevers if appropriate for the child as well. And honey with some warm or hot water in the evening also has some evidence for cough, but we can't give honey in under ones because of the risk of botulism. So we've got to be careful. So those are the general things with cough. And a few notes with babies are that if any kind of baby has a breathing difficulty, especially if they are kind of in the 3 to 12 month phase, can be a little bit older, then you have to be very careful with cough and breathing difficulties, because it could be a sign of bronchiolitis, which also would need hospital assessment usually. If there's a fever in any newborn, so that's under 3 months, and especially if under 1 month, that also needs urgent assessment, because that could be a sign of something called neonatal sepsis, which we are very, very worried about. So any of those things happen, please seek medical attention, all right, as quickly as possible. So, diarrhea and vomiting. I've regurgitated so much information at you. Are you going to be able to learn all of this for the quiz? I hope you can. So, D and V. Beautiful. Now, what is a typical diarrhea and vomiting history? Again, one that I see very frequently. Not as much as cough, but usually sounds like my child has had vomiting and diarrhea for the last 48 hours. The vomiting is now reducing because they're a 2-year-old. They usually have difficulty eating, but they're eating even less than usual, and they're still drinking enough and passing urine 3 times in 24 hours. One of us had a similar thing just before this, and we are worried about what's going to happen. They don't have any random rashes. They haven't had this before. So again, what we're looking for from that history is deviations. That specific history is indicative of something called viral gastroenteritis, but we can't make that diagnosis just based on that. What we need to do is look for what? Our friend, the dating red flags. And when we decide to hold hands with D and V and go on a date, what do we worry about them doing? We worry about them lasting longer than 7 days. It sounds long, doesn't it? 7 days, that's an awful lot of time. We worry if they've got pain, abdominal pain. In the right lower quadrant. Why? Because that's indicative of appendicitis if that happens. The more than 7 days, why do we worry? Because it's more likely to be a bacterial cause of gastroenteritis in that setting. We also worry if at some point this converts into no bowel movements. None at all. Why? Because that is indicative of bowel obstruction, a problem with the intestines. If we've got a child who is around 6 to 8 weeks old and they've got projectile vomiting, we worry about something called pyloric stenosis. That's when the exit of the stomach is too narrowed, and so the vomitus ends up coming out with a little bit too much impetus and ends up spraying on your rugus all over the wall. So yeah, we see a doctor if that happens. And then blood. So blood indicates that it could be a more serious cause as well, especially if it's lasting a little bit longer. Now, the other bits and pieces that we need to know are, has there been any change in diet recently? Has there been any recent travel? If somebody's just started eating wheat-based foods like pasta, bread, could this be celiac disease? Is there a history of that in the family? If they've traveled, have they been eating street food in Mexico and gotten themselves some kind of dysentery because of it? Now, the thing here that we're very conscious of is because if somebody's losing lots of vomit, lots of diarrhea, then they're also losing lots of salts. You lose an awful lot of potassium, which is what we worry about. And potassium is the most important electrolyte in the body to keep stable. Why? Because the heart's depolarization and repolarization cycles depend on potassium staying within a narrow limit. Usually it's between about 3.5 to 5, depending on what reference range you look at. So if it starts going too high or too low, then the heart can go into abnormal rhythms. So when we rehydrate people with diarrhea and vomiting, I would want to be thinking that if they've got more than 3 diarrhea or vomits in 24 hours, that they are taking 1 sachet of oral rehydration solution for every 3 diarrhea and vomits in 24 hours. So if they're having 9, then they'll want 3 sachets. If they're having 6, then they need 2 sachets. And that's so that they can replenish their hydration levels with water, but also the salts alongside that. There is a second reason for that, which is that if your salt levels drop too low and you just replace with water, then you can also drop your sodium levels in your blood, and it moves the water out from the blood into the tissues rather than it staying in the blood where it's needed. So how would we examine somebody with this? What kind of things would we look for? Well, we would press on their tummy and see if there's pain there in the lower right part. We also see how they look. If it's a baby, then they can vomit a little bit. That's normal after feeds. It's just white on the side. Or, if they are vomiting a lot and they're having some diarrhea, then we'd want to be, say, pushing on their stomach to see if it's rigid. Do they have something called guarding, where they do not want their abdomen to be touched at all? That could be indicative of something like a bowel perforation. Something called peritonism, where the outside of the bowel is being affected as well, rather than just the inside of the bowel. And that is a medical emergency if that happens. Now, in terms of treatments for the vast majority of cases, so we would want to do the rehydration. We want to absolutely avoid, like the plague, any kind of thing that slows down your diarrhea. So things like loperamide, for example. Lots of pharmacists will say, oh, you have diarrhea, take some loperamide. But what that does is it stops the body's compensatory mechanism. The reason why the body is giving you diarrhea is because it wants this thing, why does it look like sunshine? Oh God, it's a virus. It wants this out. Diarrhea is highly contagious. That's why people with diarrhea and vomiting are told to isolate for 48 hours after their last diarrhea and vomit, because it's full of virus. So if we are slowing down this exit process, we are essentially doing the virus's bidding for them by allowing them a long stay inside our bowel. So we don't want loperamide because it can extend the duration of illness and potentially increase the risk of complications. It's the opposite of what we want to do. So yeah, we don't do things that give us diarrhea because that can cause irritation and won't help, but let's not interfere with the natural process here. Other things we can do are obviously monitor for the 7-day period, see if things improve. We can do stool tests depending on if somebody's been traveling, what the risk index is. If somebody has some natural issues with their bowel, like if they were born with a slower bowel because of something like Hirschsprung's disease, we would want to be more likely to test that, or if somebody was premature, for example, they would be more at risk of bowel complications. Then we would know what the specific organism was. Sometimes things just carry on for 2 weeks, a month, and that's when we start thinking about, could this be more like a bacterial infection of the gut, like H. pylori, for example, or a more parasitic cause like Giardia, especially if somebody's been traveling. Those usually wouldn't come up on a standard stool test, and your doctor will need to have a high index of suspicion to say, okay, let's do a OCP, ovicysts and parasites stool test to look for Giardia, for example. So if there is a bacterial infection, we usually give antibiotics. Usually it's something like metronidazole, although you can't drink on that, so you've got to be careful. If there is a surgical cause, then operation. Okay. Now. We have, again, I hope you're paying attention. There will be a quiz. It's happening, whether you like it or not. So now we're going to be talking about rash. Rash. Now there's no typical signs of rash. Okay? There's no typical history because it's more about the way it looks. But there are certain things in a rash that make us think that it isn't just a standard viral rash, which is just generic, spread throughout the body, associated with cough, cold, runny nose. So one specific thing that we worry about is measles, especially as the vaccination rates are lowering. People are not taking MMR. This is by no means the most common cause of a viral rash, but if somebody were to have measles, the typical history would be, say, a 3-year-old child who has had cough, cold, runny nose, high fevers for 2 days, and then develops a whole body rash with red blotches that connect with each other to become bigger patches, even though they're not dry. And when you look in their mouth, they have Koplik spots. What are those? Those are bits of white grain-like sand that have red circles around them. They need to be noticed when they're there, and definitely to see a doctor, of course. Now, we also have another thing that we don't want to miss. It's called hand, foot, and mouth. Now, it's not really a red flag condition, but it's something that is quite unpleasant. So if a child develops this, let's say you've had an 18-month-old child who started nursery childcare 2 weeks ago, and they have red spots on the palm of their hands and the soles of their feet, and you look inside their mouth and there are red sores on the top of their mouth, on the hard part. That would be consistent with what? Hand, foot, and mouth. So that's caused by a virus as well. Now, usually if people have hand, foot, and mouth, they have to stay off their childcare until all of the sores have crusted over. That's the general advice. Other causes of a viral rash, especially a red flag cause, include a meningococcal sepsis. So what do we do? What do we mean by that? So if the child has been unwell, is not really able to tolerate light, has a stiff neck, and has had high fevers for a few days, if they might be a bit older, they could tell you they have a headache as well. That's bad. Also, if they develop a red rash on the body, where if you hold a glass up to the rash does not go away. Okay, so if it disappears, we're clear. Otherwise, not. So that's another red flag with rash. Of course, if you're ever uncertain, get checked out. There are other causes of rash that are quite common, including roseola. Roseola history would be 5-year-old child who had a high fever for 2 days and then developed a rash. They may not have had a cough or cold or runny nose similar to measles, but that rash would start out with a patch and then slowly spread outwards to the rest of the body. So that patch is called a herald patch. That is roseola, also very common. And not a cause for concern. The body's immune system usually clears that out within 7 to 14 days. So we can just watch and wait with those kinds of things. Other causes of rash include things like eczema. That's like a dry patch that keeps going for months and months and months. These are mainly genetic with environmental triggers. These usually will go away with really good moisturizers. The child won't be unwell. They won't have any cough, cold, runny nose. It's not infectious, but sometimes it can be misdiagnosed for other things. And another rash that we should be aware of, obviously, is chickenpox. Now, there is a vaccine for chickenpox. And we know it's chickenpox if there's something called vesicles. So that's where they have these tiny little white or colorless spots present throughout the body, particularly on the trunk, on the chest and the back. And they usually get better. Usually while this is going on, then giving them antihistamines and something called calamine lotion tends to help their symptoms. But at least if they get chickenpox, then it means that they don't get it later in life, but the virus can reactivate and become shingles at some point. That's why some people are advocating, and it's now being put into at least the UK's vaccination program, to have the vaccine for chickenpox. So that will be slowly making its way in a clinic near you. So what do we do for the other things? Well, it's totally condition dependent. Rash is quite a wide field. So I think you've learned enough to be able to handle a quiz. So let's see how much of what I've told you you have retained. So, question number 1. Let's say you have a 3-year-old child who comes to see you and they've had diarrhea and vomiting for 48 hours. The vomiting is now resolving. They've still got some ongoing diarrhea. They're eating and drinking slightly better than they were. They're passing urine about 4 times in 24 hours. And their family members haven't been sick recently. You go to have a feel of their tummy and it's soft, but they do have some pain in the lower right side. What is the likely problem here? I'll give you a few seconds. So the answer to number 1 is appendicitis. That's what we need to be worried about. So question 2. Let's use a different one. Question 2. So your child is 8 years old. They have had a cough for 2 weeks. It was initially dry, and they now have developed quite a thick green phlegm, which they're coughing up. They don't seem to have any breathing difficulties, but they keep having fevers that have been lasted for about 6 or 7 days during this time. They're eating less than usual, drinking enough, passing urine normally. People were sick about 2 weeks ago in their household, but no longer unwell. Everybody else is recovered, but your child is still unwell. What could this be? Give a few seconds. So the most likely thing would be pneumonia or a lower respiratory tract infection, because we only call it pneumonia on an x-ray, but I would accept lower respiratory tract infection or pneumonia. Then question 3. You have a child who's in Mexico on a holiday 6 weeks ago, and they felt okay while they were there. They had a little bit of diarrhea and vomiting for a day, which went away. Nobody else had it at that time, and they were eating some street food. They've been a little bit off their food since coming back. They've had some bloating. They've had a little bit of loose stools since then. You feel on their tummy, there's not really any specific area of pain. And they don't have any fevers. They've not had any vomiting now. What could this be? 6 weeks. So here I'm thinking Giardia would be top of my list. So we're just going to have 2 more questions. Let's see how many you can get. Numero 4. Considering we just spoke about Mexico. So let's say we have a patient who's come in 4 years old, has had some cough, cold, runny nose recently, had high fever for 2 days, and now has a rash across the whole body. You look inside their mouth and it looks like there's some white grains of sand with some red ring around it. What could this be? So we are looking at measles. Final question. Let's see. Should we do this hard or easy? Let's see. So you have an 11-year-old patient who comes in with a cough that's been there for the last 6 weeks. You notice that they've had some fever, some significant weight loss. They haven't traveled away recently. They are ethnically Caucasian, and you notice that they've also got some gland swelling, some night sweats, some significant weight loss during this time, and you listen to their chest. There's no changes there. What could this be? So with this patient, those are what we call B symptoms, which we went through. That's concerning for lymphoma. So how many did you get out of 5? Let us know in the comment section below, and I hope you found this useful. Let me know if you need more.